Hello fellow students, welcome to Crash Course channel. In this video, we are talking about diagnostic science. And let's start with the common symptom. First station, fever. What's the definition of fever? When the body temperature rises above the normal range in response to a homogenic source, or when the body's thermoregulatory center is dysfunctional for various reasons and is called the fever. And what's the mechanism of fever? The exogenous pathogens such as microbial pathogens, inflammatory exudates, sterile necrotic material, and antigen antibody complexes, they can activate the leukocytes, and the leukocytes will produce a factor called the endogenous pathogens such as interleukins, tumor necrosis factor, interferon. Those factors go through the blood-brain barrier to our thermoregulatory center, and it will cause the thermoregulatory points to rise up, and it will progress to fever. And there's classification of fever. In our body temperature, based on the oral temperature, the normal value of our body temperature is 36.3 degree to 37.2 degree, which is normal. But if your body temperature rises up to 37.3 to 39 degree, we call the low fever, as well as the moderate fever, high fever, ultra high heat fever. In clinical trial, we will have heat type and as well as thermal type. And what is it? The temperature value taken at different times of the day in the febrile patients are recorded separately on a temperature chart, and the temperature points for several days are connected to form a temperature curve, and those different forms of the curve are called the thermotypes. And there are five types of thermotypes. First one, retains fever thermotypes, and there are three features of it. First, the body temperature is maintained at a constant high level of 39 to 40 degrees or more for several days or weeks. Let's see the chart. You can see those degrees above 39 degree and it lasts for several days. And the second feature is temperature fluctuation range is no more than 1 degree within 24 hours. And the third one is commonly seen in lobar pneumonia and in the hyperthermic phase of typhoid fever. As for the second thermotype, tension fever, it also known as septic fever, when the body temperature is often above 39 degree with large fluctuation. You can see that's a very obvious fluctuation in the chart, and there's ranging more than 2 degree in 24 hours, and it's commonly seen in sepsis, rheumatic fever, severe tuberculosis, and septic inflammation. As the third thermotype, intermittent heat fever, the fever-free period may last from 1 to several days, and the fever-free period alternates repeatedly with a high fever period. It is commonly seen in malaria and acute pyelonephritis. We can see the charts. There's a period of time there's no fever, but it suddenly rises up more than 39 degree, and it just drops down to a normal range, and it's commonly seen in malaria. And the third and the fourth thermotypes, the wave of heat fever, the body temperatures gradually rise to 39 degree or above, then gradually decrease to a normal level after a few days, and then gradually rise again after a few days, and so on several times. It's commonly seen in brucellosis. We can see this chart looks like a wave, so we call the wave of heat thermotype, commonly seen in brucellosis. And the final thermotype, irregular heat fever, and there's no certain pattern in the temperature profile of fever. It's commonly seen in tuberculosis and rheumatic fever. It just look at this chart, it does make sense. It's just an irregular curve, and it's just seen in tuberculosis and rheumatic fever. But it doesn't mean tuberculosis heat type is just looks like this chart, and we can just say they are connected, they are associated with each other, but there's no very obvious evidence teaching that. And with the associated symptom with fever, throughout with fever is commonly seen in global pneumonia, sepsis, malaria, dry fever, transfusion or blood transfusion reactions. And lymph node swelling with fever is commonly seen in lymph node tuberculosis, leukemia, and lymphoma. If fever with liver and spleen enlargements is commonly seen in viral hepatitis, connective tissue disease, leukemia, and lymphoma. If fever with swollen and painful joints is commonly seen in rheumatic fever, connective tissue disease, and gout. And then we move to the edema. The definition of edema is excessive fluid accumulation in the interstitial space of the body tissues may stand well. And as for the classification of edema, there are three types. Systematic edema, caused by cardiogenic edema, nephrogenic edema, hepatogenic edema, endocrine edema, and dystrophy. As for the second classification, localized edema, caused by the inflammatory edema, lymphatic reflux disorder edema, venous reflux disorder edema. And as for the final one is fluid accumulation. It occurs in body cavities such as pleural effusions, pericardial effusions, and peritoneal effusion. Okay, let's elaborate. For the cardiogenic edema, there's four features of it. It is first seen on the lower part of the body like medial ankle, and the face is usually not swollen in comparison to the nephrogenic edema. And the second is upward movements obvious after activity relieved by rest. And the third is this edema is symmetrical and is concave. And the last one is often accompanied by jugular vein anger, hepatomegaly, chest, and abdominal fluid. And the common disease caused the cardiogenic edema is right heart failure. And then we move to the nephrogenic edema. The mechanism of nephrogenic edema, there's two kinds of it, the nephroinflammatory and the nephropathetic. As for the nephroinflammatory, the reason is decreased renal excretion of sodium, and water leads to water sodium retention and increased extracellular fluid, and it causes the edema. As for nephropathic, the reason is hypoproteinemia resulting in a decrease in colloid osmotic pressure. And the features of nephrogenic edema is the two kind of mechanism plus the heavy proteinuria. And in the early stage, stage, there's edema of the eyelids and face when waking up in the morning, which later develop into generalized edema. If you wake up and you see your eyelid or face are swollen, it's probably there's something wrong with your kidney, because it is commonly seen in nephrogenic edema. The common disease is various glomerulonephritis and nephropathy. And there's a comparison between the nephrogenic edema and cardiogenic edema. You see, the start size of nephrogenic edema is eyelid and face. And as for the cardiac edema, it starts from the foot, like the medial ankle. And there's concomitant signs with nephrogenic edema, carries urinary changes, renal impairment. But as for the cardiogenic edema, there's enlarged heart, murmur, hepatomegaly associated with cardio edema. And then we go to the hepatogenic edema. And the generation mechanism of hepatogenic edema is portal hypertension, hyperproteinemia, hepatic infective fluid reflux disorder, and secondary aldosteronism. And the features of hepatogenic edema is ascites. It's very obvious. And then we go to the endocrine edema. There's 4 kinds of disease caused the endocrine edema. First, hypothyroidism. The mechanism of hypothyroidism is decreased hyaluronidase activity, and the tissue interstitial hyaluronic acid and mucopolysaccharide increase, and is often accompanied by slow heart rate and low blood pressure. And the clinical features of hypothyroidism is non-depressed, and the edema is not affected by the body position, and the edema area is accompanied by skin thickening, roughness, pallor, and decreased temperature. And then we go to the hyperthyroidism. It still causes the edema, and they are the opposite, the hypothyroidism and hyperthyroidism. As for the hyperthyroidism, the autoimmune inflammation leads to fibrous tissue proliferation, mucopolysaccharide and glycosaminoglycan deposition, and an increase in translucence, increased transparency and acidity. And as for the features, this edema is sunken edema, and it's local restricted mucinous edema. And then we go to the Cushing syndrome. The mechanism of Cushing syndrome is adrenocorticotropic hormone increase water and sodium storage causes the edema. In several cases, we can see edema, but in most cases, we couldn't see edema. And then we go to the last one, primary hyperaldosteronism. The mechanism of it is increased aldosterone due to adrenocortical lesions with water and sodium storage and low potassium. And the features of primary hyperaldosteronism is mild lower extremity and facial edema, and main symptoms are hypertension, muscle weakness, because there's low potassium causes the muscle weakness. And then we go to the final one, edema caused by the connective tissue disease, and it is non-depressed edema, and the redness and swelling of the head, face, neck, and upper extremities is obvious thing. The common disease is SLE and dermatomyositis. Okay, let's move to the coughing and sputum. Actually, coughing is a good thing because it is a protective reflex. If there's something in our airway and this is so bad and we have to cough up, so that's why it is a protective reflex. But if we cough up sputum, this is not good. It's a pathological reactions commonly seen in respiratory tract infections, pulmonary parasitic disease, pulmonary stasis, and pulmonary edema. And there are 4 reasons cause coughing. First, respiratory disease, and respiratory tract infection is the most common cause of cough and sputum. And second, pleural disease. Third, cardiovascular disease like left heart failure due to the mitral stenosis. And the last one is central nervous factors like meningitis, encephalitis. And as for the clinical manifestation, there are some conclusions below. As for the dry coughing, it's commonly seen in pleural disease like often with the chest pain, and pharyngitis, laryngeal cancer, early stage of acute bronchitis. And as for the moist cough, often with a fever and continuous pus sputum, is commonly seen in chronic bronchitis, bronchiectasis, pneumonia, lung abscess, cavitary tuberculosis. And as for the tone of coughing, we have 2 tones of cough. Like the first one is hoarse cough. It's more like a half cough. It's like a rough cough, you know. It's commonly seen in inflammation of the vocal cord or tumor compressing the recurrent laryngeal nerve. Then we have the metallic tone cough. It's commonly seen in mediastinal tumor, bronchial cancer, often with blood in the sputum compressing the trachea. And then we go to the sputum properties and volume. If there are lots of sputum, it's commonly seen in bronchiectasis, lung abscess, and bronchopleural fistula. If it is the yellow-green or emerald-green sputum, it's commonly seen in Pseudomonas aeruginosa infections. If it is the white and sticky sputum that's difficult to cough up, and sputum that's put into silk, kind of like a shape, and it's commonly seen in fungal infections. And if it is the rust-colored sputum, it's commonly seen in pneumococcal pneumonia. And there's a common symptoms with coughing. If the coughing with hemoptysis is commonly seen in bronchiectasis, tuberculosis, lung abscess, bronchopulmonary cancer, mitral valve stenosis, etc. If the coughing with growing sound is commonly seen in bronchial asthma, cardiogenic asthma, chronic obstructive pulmonary disease. If the coughing with pastel fingers is commonly seen in bronchiectasis as well, chronic lung abscess, brachial lung cancer. Okay, let's move to the hemoptysis. The definition of a hemoptysis is bleeding from the larynx and any part of the respiratory tract below the larynx and the lung with hemoptysis via the oral cavity. The diagnosis of hemoptysis, the first step is to identify other sources of blood coughing from the mouth, like the oral cavity, nose and pharynx, and digestive tract. And step 2 is initial determination of the cause of hemoptysis based on the characteristics, amount of color, age, and accompanying symptom with hemoptysis, usually from the foreign disease, like those 3 diseases. The first one is brachial tube, and the second one is lungs, and the last one is heart disease, like the left heart failure leading to pulmonary stasis is the most commonly seen. As for the brachial tube, is commonly seen in bronchiectasis, recurrent hemoptysis with chronic cough and thick sputum, and bronchopulmonary cancer, intermittent hemoptysis, and there's blood in the sputum, and brachial tuberculosis, brachial adenoma. As for the lungs, it's commonly seen in tuberculosis, pneumonia, lung exam, pulmonary embolism. And as for the heart disease, it's commonly seen in acute left heart failure, and the hemoptysis is pink and foamy, and mitral stenosis, and the hemoptysis is dark and red, and pulmonary hypertension. And there are some conclusions related with hemoptysis. If you are young, it's commonly seen in tuberculosis, bronchiectasis, mitral valve stenosis, etc. If you are old, like over 40 years ago, long history of smoking is commonly seen in bronchopulmonary cancer. And as for the amount of hemoptysis, if it is a massive amount, if you just puke a lot of blood, which is more than 5 milliliter each time, it's commonly seen in cavitary tuberculosis, bronchiectasis, chronic lung abscess. If it's just a small amount of hemoptysis, you puke like less than 100 millimeter, it just is commonly seen in bronchopulmonary cancer. And the color of the trains of the blood that you puke up, if it's bright red color, it's commonly seen in tuberculosis, bronchiectasis, lung abscess, hemorrhagic disease. If it's rust colored blood flame, it's commonly seen in pneumococcal pneumonia. If it's brick red jelly-like blood sputum, it's commonly seen in Laibacilla pneumonia. And if it's dark red sputum, or the blood, is commonly seen in mitral stenosis. If it's the plasma pink foamy and bloody flame, it's commonly seen in left heart failure. And there's still some conclusion between the hemoptysis and blood vomiting, because we couldn't identify where it comes from, the digestive tract or just the trachea or the lung. We can see the difference between the cause of disease, pre-hemorrhagic symptoms, hemorrhagic mode, scarlet, blood mixed with something, reaction, black stool, post-hemorrhagic sputum properties. As for the hemoptysis, it's throat tickling with chest pain, coughing, etc. And it's cough up. It's not like vomiting. And the scarlet is bright red, and the reaction is alkaline because there's no any acid in our lung or trachea or anything that just puke up from our trachea, not from the digestive tract. So that's a very big difference, and it often puke up for several days. But as for the blood vomiting, the scarlet is brownish black, dark red, and sometimes bright red if you just vomit a lot of blood, and it accompanied with food residues and gastric juice, and it is acidic because of the gastric juice. And there's black stool, and vomiting blood will still persist for several days after it stops, and there's no friend. And then we move to the chest pain. Mechanism of chest pain, there are 4 kinds of mechanism of chest pain. Intercostal nerve, sympathetic fiber innervating the aorta, vagus nerve fiber innervating the trachea and bronchi, and sensory fibers of the phrenic nerve. If those nerves have been influenced, and it causes the chest pain. And there's a very specific related with chest pain, and it is the radiological pain. What is it? The angina pectoris can also be radiated to the left shoulder, left inner arm, or left neck, or left trunk, in addition to an anterior region and retrosternal pain. And there are some conclusion about the chest pain. If you are young, the common disease is usually seen in tuberculosis, pleurisy, spontaneous pneumothorax. If you are old, like 40 years old and above, it's commonly seen in angina pectoris, myocardial infarctions, bronchopulmonary cancer. And the precision of the chest pain is still important. If the chest pain is often fixed in the chest wall, it's the inflammation of the chest wall, herpes zoster, not exceeding the midline of the body surface of herpes zoster. If the position is in posterior sternum and precordial area, it's commonly seen in angina pectoris and myocardial infarction. If the chest pain is in lateral parts of the chest, it's commonly seen in pleurisy, subdiaphragmatic abscess. And then, as for the characteristic of chest pain, if the pain is like severe cutting or burning pain, it's commonly seen in herpes zoster. If the pain is like cramp-like pain, suffocating sensation, it's commonly seen in angina pectoris, myocardial infarction. If the pain is like tearing-like, it's commonly seen in spontaneous pneumothorax. And then there's some influence factors of chest pain. If it's strain or mental stress induced, it's commonly seen in angina pectoris, myocardial infarctions. If it's seizure or exacerbating during eating, it's commonly seen in esophageal disease. If it's coughing or exertional breathing apparatus, it's commonly seen in pleurisy and pericarditis. And then we give these 4 diseases to compare with. The first one, angina pectoris. The position is posterior sternum and precordial area, and the age is most old man. And the infant factor is relieved within 2 to minutes after rest or after nitroglycerin or isosabite nitrate. As for the myocardial infarctions, it's still old man, and the position is the same compared to the angina pectoris, but the pain lasts for a long time, and there's no medicines that can cure it. If you take the nitroglycerin and the pain are not reduced, it indicates the patient has myocardial infarction. If it's spontaneous pneumothorax, it happens in young kids. It's like tearing like pain. It's commonly seen in lean and tall body types that can trigger by severe coughing, and there are some breathing difficulties accompanied. If it's the esophageal cancer, it happens in the middle-aged people. It happens in posterior sternum. The pain starts from posterior sternum, and the influences is seizure and exacerbation during eating, and dysphagia is accompanied. Okay, we move to dyspnea, and there's 5 sorts of dyspnea: the pulmonary derived dyspnea, cardiogenic dyspnea, toxic dyspnea, and neuropsychiatric dyspnea, and hematogenous dyspnea. As for the pulmonary derived dyspnea, it's commonly seen in brachial asthma, chronic obstructive pulmonary disease, pulmonary stasis, pulmonary edema, diffuse interstitial lung disease, and pleural effusion. As for the cardiac dyspnea, it's commonly seen in left heart or right heart failure and pulmonary embolism. And as for the tonic dyspnea, it's commonly seen in diabetic ketoacidosis, organophosphorus pesticide poisoning, and acute carbon monoxide and poisoning. And as for the hematogenous dyspnea, it's commonly seen in severe anemia. And let's elaborate each of them. As for the pulmonary derived dyspnea, there's 3 classification of it: as per aspiration dyspnea, and mixed dyspnea. And the time frames of each of them is different. And the physical sign of aspiration dyspnea is there's a triple concave sign. It's obvious been seen, which contains about the suprasternal fossa, supraclavicular fossa, and intercostal space. And the mechanism of aspiration dyspnea is upper airway obstruction and negative thoracic pressure during inspiration. It's commonly seen in laryngeal, tracheal, and bronchial obstruction. As for the aspiration dyspnea, the physical sign is prolonged expiratory time, like a croup. The mechanism of aspiration dyspnea is lower airway obstruction and decreased alveolar flexibility. It's commonly seen in chronic branch brachial asthma and chronic obstructive pulmonary emphysema. And as for the mixed dyspnea, the physical sign is abnormal breath sound and pathological breath sounds. The mechanism of mixed dyspnea is reduced ventilation area and ventilation dysfunction. It's commonly seen in pulmonary embolism, often with the chest pain, diffuse interstitial lung disease, pleural effusion, and pneumothorax. And as for the cardiogenic dyspnea, there's 2 types of it: left heart failure causing dyspnea and right heart failure causing dyspnea. As for the left heart failure causing dyspnea, there's 4 mechanisms of it. First, the pulmonary stasis cause the gas diffusion functions decrease. Second, alveolar tone increase. And the third, alveolar elasticity decrease. And the last one is pulmonary circulation pressure increase. It can just reflux the stimulation of respiratory center, and it just, your respiratory rate will be increased, and you couldn't, you're short of breath, and you're just causing dyspnea. And the features of the left heart failure causing dyspnea is appearing or worsening during activity, relieving and rest. Normal paroxysmal dyspnea, even cardiac asthma with clear foaming sputum, and increase in supine position, decrease in seated position. And most of our patients will have a very special position to just get better when during the dyspnea, and it's the seated breathing. It's commonly seen in rheumatic heart disease, hypertensive heart disease, and coronary arteriosclerotic heart disease. And as for the right heart failure causing dyspnea, there's 3 features of it: right atrial and superior vena cava pressures increase, stimulating pressure receptors to excite the respiratory center. And the second is blood oxygen level is decreased. Acidic products accumulates and stimulates the respiratory center, and you just, your respiratory rate will be increased. And the last one is stasis hematomegaly, pleural fluid ascites, restriction of respiratory movement, and it's commonly seen in chronic pulmonary heart disease. And as for the toxic dyspnea, and there's 3 classifications: metabolic acidosis, CO intoxication, and organophosphorus poisoning. And as for the metabolic acidosis, the features is Kussmaul breathing, deep, long, and regular breathing, often with snoring. It's commonly seen in diabetic ketoacidosis and renal failure. And as for the CO intoxication, the obvious feature is the lips are cherry red, and it's commonly seen, of course, is in CO poisoning. And if it is the organophosphorus poisoning, the features is smooth muscle spasm, increased granular secretion and is commonly seen in organophosphorus pesticide poisoning. And then we move to the blood vomiting. And what's the blood vomiting? The definition of it is a disease of the upper gastrointestinal tract, referring to the gastrointestinal tract above the flexural ligaments, including esophageal, gastric, duodenal, hepatic, biliary, and pancreatic disease, or upper gastrointestinal bleeding due to systemic disease with blood vomited through the mouth. And if we have blood vomiting, we can associate it with black stool. How can create the black stool? Why our stool is black? It mainly depends on the bleeding speed, bleeding volume, and bleeding site in our digestive tract. If it's rapid and massive bleeding, it mainly manifests with vomiting blood and bloody stools. If it's slow bleeding rate and small amount, it mainly manifests as black stool, and there's some conclusion about the blood vomiting. If it's esophageal disease, like the cancer, the clinical features will be progressive dysphagia and blood vomiting. If it's the gastric and duodenal disease, like the peptic ulcers, is most commonly in young adults, vomiting flash blood or black stool with periodic epigastric pain. If it is acute erosive hemorrhagic gastritis, it's commonly in cranial trauma like Cushing ulcer, massive burns, curling ulcer, oral enzyme drugs, vomiting blood might be brown or coffee-like material. If it is stomach cancer, the feature is middle-aged people and elderly male with chronic irregular epigastric pain with raised low and edema. And the last one is portal hypertension. This is commonly seen in esophagogastric fundus varus. The feature of it is vomiting of large amounts of blood, often greater than 500 mm, resulting in shock with hepatosplenomegaly. And there's two more ways cause the blood vomiting: the biliary hemorrhage and systemic disease. As for the biliary hemorrhages, the feature is periodic upper gastrointestinal bleeding, like 200 to 300 mm, 1 to 2 weeks apart, accompanied by jaundice and right upper abdominal cramps. It's commonly seen in gallbladder cancer, bile duct cancer, liver cancer, and liver trauma, and etc. And as for the systematic disease, there's blood disorders like thrombotic to panic purpura, application of anticoagulants overdose, or infectious disease like epidemic hemorrhage, fever, leptospirosis. And then we move to the abdominal pain, and there are 3 kinds of abdominal pain classification: visceral abdominal pain, somatic abdominal pain, involvement abdominal pain. As for the visceral abdominal pain, the pain site is close to the abdominal midline and is often accompanied by other symptoms of autonomic excitation such as nausea, vomiting, and sweating, which is in early stage of appendicitis is visceral abdominal pain. As for the somatic abdominal pain, the feature of it is accurate localization, maybe on the side of the abdominal, intense and continuous in degree, and there might be localized abdominal muscle tonicity. And in the late stage of appendicitis, it is the somatic abdominal pain. And the last one is involvement pain. The features of it is it has sensory hypersensitivity. And in the middle stage of appendicitis, we can see the involvement pain. And as for the clinical manifestation of abdominal pain, the location is in the upper and middle abdomen, and it's commonly seen in gastric, duodenal, and pancreatic disorders. If the pain is in right upper abdominal, it's commonly seen in cholecystitis, cholelithitis, liver abscess. If it's right lower abdominal pain, it's commonly seen in acute appendicitis pain, and if it's umbilical or peri-umbilical pain, it's commonly seen in small bowel disorders such as acute gastroenteritis, small bowel obstruction. And as for the nature and extent of abdominal pain, first, sudden onset of severe kind-like pain and burning pain in the upper and middle abdomen is commonly seen in perforated gastric and duodenal ulcer. If it's the persistent periodic vein pain in the middle and upper abdomen, is commonly seen in chronic gastric and duodenum ulcers. If it's the persistent dual pain or kind-like pain in the upper abdomen with paroxysmal increase, is commonly seen in acute pancreatitis and it will cause shock with the patient. If it's a paroxysmal severe colic with patient tossing and turning, it's commonly seen in cholelithitis with fever, nausea, vomiting, and jaundice, and urinary stones. If it's the paroxysmal subsequent during night pain, is commonly seen in biliary ascariasis. If it's persistent widespread severe abdominal pain with abdominal wall muscle tension or plate-like tonicity, it's commonly seen in acute diffuse peritonitis. And there's a differentiation of 3 types of colic: intestinal colic, cholestasis, and renal colic. The pain signs of each colic is different. As for the intestinal colic, it's around the umbilicus and lower abdomens, and accompanied with nausea, vomiting, and the bowel sound will be increased. It's commonly seen in mechanical intestinal obstruction. As for cholestasis, it's located in right epigastrium radiating to the right dorsum and right scapula, and it always accompanied with jaundice and fever. It's commonly seen in gallbladder stones, acute cholecystitis, and common bile duct stones. If it's the renal calyx, it's located in lumbar region and radiating to the perineum, and in company with the urine-containing protein (RBC), and it's commonly seen in urethral calyx. And there are some predisposing factor and previous history causing the abdominal pain. If the history of the eating greasy foods, it's commonly seen in cholecystitis and cholelithiasis. If the patient with history of alcohol abuse and binge drinking, it's commonly seen in acute pancreatitis. If the patient with nocturnal fasting pain, it's commonly seen in duodenum ulcer. If the patient with history of abdominal surgery or abdominal inflammation, is commonly seen in adhesive mechanical intestinal obstruction. If the patient with history of atrial fibrillation, is commonly seen in mesenteric vascular ischemic disease. And when the patient have the abdominal pain, they will have a very special posture. If it is a knee, chest, or prone position, which can relieve symptoms such as abdominal pain and vomiting, is commonly seen in duodenal congesting syndrome. If it is the anterior tilt or prone position, it's commonly seen in pancreatic body cancer. Okay, let's move to the very important section, jaundice. It is very important for an intern or for a doctor if you work in a clinic. If you see a patient with yellow eyes, the first impressions you have to think about if the patient has jaundice or not. In our body, we have normal serum bilirubin, which is between 1.7 to 17.1 mole per liter level. If the patient has jaundice, we couldn't see the bilirubin range from 7.1 to 34.2 mole per liter. But if we can see, this patient has the jaundice symptom, and the serum bilirubin in that patient will be increased above 34.2 mole per liter. And first, let's talk about the mechanism of bilirubin metabolism, which is very difficult to understand, but here we go, let's look at it. In our blood circulation, we know we have lots of RBC, which is erythrocytes, and those RBCs have a life which lasts for like 120 days. And those RBC become older, and we have macrophage, the immune system in our blood circulation. Like the macrophage will eat the RBC, and those RBC will be degraded to hemoglobin. And those hemoglobin in our blood circulation will have a series of chemical reactions like degradation of hemoglobin and passage by histoproteinase, and conversion to bilirubin by catalase, and reduction by reductase, and binding to serum albumin to form unconjugated bilirubin, which is free bilirubin, as well as called UCB, and it cannot be filtered out from the glomerulus, which is the kidney, and those unconjugated bilirubin will be transported through the blood circulation to the liver, and those UBC will combine two carrier protein, which is Y and Z, to glucuronosal transferase in hepatocytes, catalyze binding of glucuronide to form conjugated bilirubin, which is CB, and it's water soluble, and it can be excreted in neuron by glomerular filtration. And what does this sentence mean? It means the elderly RBC in our blood circulation will be eaten by the macrophage of our immune system and become hemoglobin. And those hemoglobin will go through a series of chemical reactions and become UCB. And those UCB will go to liver and combine with this kind of glucose, and with the help of gluconoxide transferase, and become CB. And those CB in the liver will go to the bowel and become urobilinogen. And then most of the bilinogen is excreted from the feces, and then we call the fecal bilirubin. And there's a small amount of intestinal urobilinogen enters the liver by the portal vein. So it is a cycle we call the hepatic intestinal cycle. And of course, we can see there's still a way. There's some urobilinogen go to the kidney and become urobilinogen. And then this is the normal mechanism of the bilirubin metabolism in our body, which is normal. Everybody have it. But how about the patient with jaundice? It's just about there are some problems between these airways, in these pathways. So if there are some problem inside these pathways, it will cause the jaundice, which means like the CB will increase or UCB will increase, and we can see there's a lot of the yellow pigments in our iris, in our eye. Okay, let's go to the classification of jaundice. There are three important classifications of jaundice. First, hemolytic jaundice. Second, hepatocytic jaundice, and the last one is cholestatic jaundice. And let's elaborate each of them. As for the hemolytic jaundice, why it happens, and there's two kinds of etiology. First, congenital hemolytic anemia, such as maritime anemia, hereditary spherocytosis, and the second one is acquired hemolytic anemia, such as autoimmune hemolytic anemia, hemolysis after transfusion of different blood types, snake venom, paroxysmal sleep, hemoglobinuria, etc. The mechanism of the hemolytic jaundice is destruction of a large number of erythrocytes, which is RBC, and formation of large amounts of unconjugated bilirubin. So let's look at this picture. And as for the hemolytic jaundice, which means there are lots of RBC, no matter how old it is or how young it is, they have been, they have been broken, and the macrophage damage eats all of them, and those large amounts of RBC become a large amount of UBC. And the features of a hemolytic jaundice is the jaundice is mild, lint lemon in color, and not accompanied by itchy skin because the UCB is not water soluble. So that's why it doesn't accompany with itchy skin, not as CB. If the CB increase and it is water soluble, it will have itchy skin. Your skin will be so itchy everywhere. And the second feature of the hemolytic jaundice is fever, chills, headache, vomiting, and back pain may be present in acute hemoptysis. And with varying degrees of anemia and hemoglobinuria, severe cases may have acute renal failure. The lab test of this hemolytic jaundice, the TB, the total bilirubin, will be increased, and its meaning UCB will be increased, and CB was basically normal. Urinary bilirubin increase in blood and is excreted from kidney. So urinary urine bilirubin increased but without bilirubin. And as for the hepatocytic jaundice, the etiology is like, viral hepatitis, cirrhosis, toxic hepatitis, and sepsis. The mechanism of this is damage to hepatocytes results in reduced uptake and binding of bilirubin by hepatocytes. The clinical feature of the hepatocytic jaundice is light yellow to dark yellow skin and mucous membrane, may be accompanied by mild itching of the skin. And the second is poor liver function in severe cases, may have bleeding tendency, ascites, coma. And the lab test of hepatocytic jaundice is increased UCB and UCB in blood, positive urine CB, qualitative TF, while urine bilirubin may be increased due to liver dysfunction. And let's go to the picture again about this hepatocytic jaundice. It's just about the liver cells have been damaged a lot, and why it caused the UCB and CB increase. The UCB is here, the CB is in the liver, the UCB is in the blood circulation, and why the liver cell damage can cause UCB and CB increase. It doesn't make sense at all, right? But actually it does, because when the liver cells damage a lot, the construction of liver have been damaged, the UCB could not go to the bowel, so it just go back to the blood circulation. So that's why the UCB increase. And why the CB increase is because I messed up, I'm sorry. Let me just say again. Why the CB increase is because there's so many liver cell damages, and the construction of the liver have been damages as well. So that's why the CB have to go back to the blood circulation. So the CB increase, and the UCB increase is because I think it's still the same. The UCB increase is still the same about the mechanism. Okay, let's go to the biliary jaundice. Etiology of biliary jaundice is common bile duct stones, biliary strictures, biliary tract tumors, intrahepatic sediment light stones, primary biliary cirrhosis. And the mechanism of the biliary jaundice is the bile duct obstruction and the bilirubin in the bile flow back to the blood. Which look at the picture, it's just like those CB, those conjugated bilirubin could not go to the bile, could not go to the intestine because there's obstruction in the bile duct. So the clinical feature of the biliary jaundice will be dark yellow skin, dark or even yellow green for complete obstruction with pruritus and bradycardia, and dark urine, pale feces, and white clay color. This is very important if the patient's stool is white, which means there are no any fecal bilirubin defecated. So that's why the stool is white. The lab test of biliary jaundice is increased serum CB, positive urine bilirubin test, decrease or absence urinary bilirubin and fecal bile, and increased serum alkaline phosphatase and total cholesterol. And there's concomitant symptoms. Jaundice with fever is commonly seen in acute cholangitis, liver abscess, viral hepatitis, acute hemolysis. If the jaundice with severe epigastric pain is commonly seen in biliary stone, liver abscess, and biliary ascariasis, severe right upper abdominal pain, chill, and hypothermia, and jaundice as Charcot sign, triad sign suggests acute cholangitis. If the patient with gallbladder enlargements and jaundice, it indicates the obstruction of the common bile ducts, commonly associated with cancer of the head of the pancreas, cancer of the jugular belly, cancer of the common bile ducts, and stone of the common bile duct. If the patient with jaundice and ascites is commonly seen in severe hepatitis, cirrhosis, decompensated stage, and liver cancer. Okay, let's move to the hematuria. And there's two kinds of hematuria, which is microscopic hematuria or the hematuria of the naked eye. That we can see in hematuria, the urine is bloody, but we couldn't see the urine is bloody in microscopic hematuria because the urine color is normal and can only be determined by microscopic examination, usually after centrifugation and precipitation of urine, and there's more than 3 RBC per high magnification field of view on microscopic examination. And as for the the urine that we can see, the urine is the color of the washed water or blood. Hematuria that is visible to the naked eye, and urine containing more than 1 millimeter of blood per liter. So if your urine is bloody, don't worry about it. You just have 1 millimeter of blood per liter. It's not a lot of blood, just a few, just 1 millimeter of blood. You don't need to be panicked about. And as for the etiology of hematuria, there are three kinds of etiology. First, disease of the urinary system, which is most commonly cause the hematuria. First, glomerular disease, such as acute and chronic glomerulonephritis, IgA nephropathy, hereditary nephritis and thin basement membrane nephropathy, and various interstitial nephritis. And as for the urinary bladder inflammation and neoplasms cause the hematuria, it's commonly seen in urinary tract infection, urinary stones, urinary tuberculosis, and urinary tract tumor. And if it's the vascular abnormality causing hematuria, it's commonly seen in left renal vein compression, which is nutmeg syndrome. And we can see this picture of the nutmeg syndrome is just like this left kidney vein has been compressed by the mesenteric arteriole. And as for the systemic disease that can cause hematuria, we have infectious disease, blood disorder, and autoimmune disease. As for the infectious disease caused hematuria, it's commonly seen in sepsis, epidemic, hemorrhagic fever, and leukemia. And for the blood disorder caused hematuria, it's commonly seen in thrombocytopenic purpura, hemophilia. And as for the autoimmune disease, it's commonly seen in rheumatoid arthritis, systemic sclerosis. And then there are some urinary tract adjacent organ disease that can cause hematuria. It's commonly seen in acute and chronic prostatitis, acute pelvic inflammatory disease or abscess, and acute appendicitis. And the clinical manifestation of hematuria, there's some conclusion of it. The color change and the sediments, urine abnormality, and the microscopic hematuria. If the urine is dark and red, it's commonly seen in the kidney bleeds. If the urine is bright red, it's commonly seen in bleeding from the bladder or prostate gland. And if the patient goes to the clinic, goes to the hospital, and we have a the urine test, like the segmental urine test, which we let the patients pee, and we use the cup to just contain the pee, and there's 3 cups of the whole pee, the whole urine. And if the hematuria in the beginning, it's commonly see the lesion is in the urethra. If the urine is in the terminal, it's commonly see the bleeding in the black neck triangle and prostatates and seminal vesicle glands. If the 3 cups contains the hematuria, it's commonly seen in kidney and urethra, and when the lesions are there. And as for the microscopic hematuria, there's nephrogenic hematuria and prosrenal hematuria. As for the nephrogenic hematuria, it's mostly from the glomerulonephritis, and we can see in the microscopic the RBC vary in size and methodology. And as for the postrenal hematuria, it moves from the postrenal sources. And in the microscopic, we can see the RBC is single and approximates to peripheral blood, which is normal. It's just the RBC is normal. There's no any changes in their size or methodology. And there's concomitant symptoms with hematuria. If the hematuria with renal colic throughout the naked eye or microscopy is commonly seen in kidney or urethra stone. If the hematuria with interruption of the urine flow out through, it's commonly seen in blood and urethra calculus. If the initial hematuria with fine urine stream and difficulty in urination, it's commonly seen in prostatitis and prostate cancer. If full microscopy and coronal hematuria with frequent and painful urination, it commonly seen in cystitis and urethritis, accompanied by a back pain, high fever and chills, and painful percussion in the kidney area is often pyelonephritis. If the microscopic hematuria with edema, hypertension, and proteinuria is commonly seen in glomerulonephritis. If the hematuria with bleeding from skin mucous membrane and other sites is commonly seen in blood disorder and certain infectious disease. And last but not the least, let's go talk about the consciousness disorder. When we have this consciousness disorder, it can be caused by infection, poisoning, and mechanical compression, like the severe acute infection such as sepsis, pneumonia, toxic biliary dysentery, or maybe cranial non-infectious disease such as cerebral ischemia, cerebral hemorrhage, hypertensive encephalopathy, brain tumor that can cause consciousness disorder, and endocrine and metabolic disorder, water and electro balance disorder, and exogenous poisoning. Those kind of reasons can cause consciousness disorder. And there's concomitant symptoms with consciousness disorder, like pupils narrowing, skin mucosal changes, bleeding spots, petechia and purpura, and cherry red limbs, which is commonly seen in carbon monoxide poisoning, and bradycardia, which is commonly seen in intracranial hypertension, atrioventricular block, and morphine-like mushroom poisoning, etc. And there's 5 types of consciousness disorder. Drowsiness, a pathological sleepiness in which the patient falls into a continuous sleep state. He can be awake and he can answer and respond correctly, but fall back to sleep soon after the stimulant is removed. And the second type is blurred consciousness, a disorder of consciousness in which the level of consciousness is mildly reduced and deeper than drowsiness. The patient is able to maintain simple mental activities, but the ability to orient time, place, and people becomes impaired, which means they don't know where they are, who they are, and what they are doing. When the accident happened, they don't know about that. And we go to the type 3, lethargy, a state of consciousness that's close to unconsciousness. The patient is in a deep sleep and cannot be easily awake, and the patient may be awaked by strong stimulation like pressure on the supraorbital nerve, shaking the patient's body, and etc. Soon fall back to sleep. And the type 4, coma. And there's 3 kinds of coma: mild coma, moderate coma, and deep coma. Coma is severe impairment of consciousness, manifested as a sustained interruption or complete loss of consciousness. It can be divided to 3 stages, which is mild coma, moderate coma, and deep coma. And for the mild coma, it still has the corneal reflex, pupil to light reflex, eye movements, swallowing reflex. But as for the moderate coma, those reflex will be diminished but still exist. But as for the deep coma, all of the reflex were gone. And then we have the type 5, delirium. It is acute dysregulation of the activity of higher nerve centers, mainly due to increased excitability, manifests by blurred consciousness, disorientation, sensory confusion like hallucination and delusion, restlessness, and garbled speech. Okay, this is the end of the common symptoms of the diagnostics science, and we'll see you in the next video. Have a nice day. Bye.